Good morning, everybody. Thank you for the patience. We're going to call the June meeting of the Board of Health to order. For the record, there's a copy of the Open Meetings Act in the legislative chambers. I have official notice of publication with me. With that, roll call.
Okay. Wilkins? Here. Rogers?
Here.
Wade?
Yep.
Weiss? Here. Gray?
Here.
Espinoza? Here. And Tucker?
We'll go to item 2, an approval of the minutes for the May meeting. Is there a motion?
Motion approved.
There's a motion. Is there a second?
So moved.
Roll call.
Rogers?
Yes.
Wade?
Yes.
Espinoza? Yes. Wilkins? Abstain. Weiss? Yes. And Denver?
Yes.
With that, we'll go to item 3. Anybody from the public have any comments on any items not listed on the agenda? Seeing none. Okay, we're going to do a little change here to get through the day. So what I'm going to do is go down to item 5, and we're going to address letter A. Then we'll go back to the action items and then come back to B. So what I'd like to do, I'm assuming, Kari, you're going to come up for, or you're going to come up for A. Oh, Dr. Poore, sorry. So we're going to do this. Dr. Poore's going to get into A, and then what I'd like to do, and I don't know if anybody's on, but once we get through explanation of item A and go through the action particular items, if anybody wants to comment, particularly on, item H, that's what I asked for the Zoom to be set up, because when we get ready to go into that, there's a lot of work from the staff. Some may not be here, but if anybody wanted to chime in, I wanted to give them an opportunity to comment on this specific period. So if people are following me, we'll go from there, and then we'll let the board say any comments and go through the resolution. So with that, we'll go to item 5A, and Dr. Poore.
Good morning, board. Is this on? Yeah. Okay. Is this on? Okay, good.
No.
Because these don't work.
It's green,
You need to put some money into this system. It seems every day there's something new here. So first of all, I like to make a few comments, and then I will have Kari also talk about it, and they are related to the resolution that you have on your agenda today. But before I start to go into the resolution, I want to share with the board and also with the community that the last 2 weeks have been really hard. They have been hard for our community, and I think we want to share with them that we are here for them. We are hearing you. We are hearing your pain, your cry for justice, and we want to be part of the solution. So that's why the resolution is on today's agenda. Racism is a public health crisis. This is very bold and very courageous, and I tell you, I'm very, very proud of you as a board to really start to think about it and try and hopefully adopt this resolution today. I have been with the health department for many years, as you know, and since we declared STD as an epidemic, I think this is the biggest, boldest step that this department has taken. We are not only calling it a public health issue, because that is what many counties do around the nation. We are calling it a public health crisis. And I just want to make clear why we are calling it a crisis. And it is going along with the definition that has been used for crisis. The problem has to affect a large number of people. It cannot just affect one person. Well, we know it affects a large population in our community. We have a minority community of 29% of our total community in Douglas County. Then the other definition is that it must fit in. It must threaten health over a long term of time. Long term. It can't just be something that happens quickly. But when we look back at the community needs assessment that we have done since 2002, we have shown health disparities in those community needs assessment since 2002. So this has been going on for a long term, and we are not going to be able to fix this and turn this around in a short period of time. And the third one, probably the most important one, is also, this is requiring a large solution. This isn't a small little tweak that needs to be done here and there. This is big. This needs to involve everyone in our community. It can't just be done by one organization. So the resolution points to 18 facts, and we have copies of the resolution out there, and we'll put it on our website for all the community to really see. And some of them they all are things that you as Board of Health members have seen over the last many years. I mean, you know that when we talk about the mission of the health department, we always aspire for health for all. That's always in our mission statement. You know about the numerous studies that have linked racism to health outcomes. I mean, there are more than 100 studies. We also, and I have shared with you every year when we look at our data and we talk about the state of public health, we have pointed out where the health disparities are in Douglas County. We have shown to you that whites on an average have a life expectancy of 10 more years than African Americans. We have talked about infant mortality, and we have tried to address it over many years, but we still know that a baby born to an African American mom has close to a 3-fold higher chance to die before their first birthday compared to white Americans. We know that cardiovascular disease in our African American population is up to 60% higher than in our whites. We know that diabetes is at 16% in our African American population, whereby it's only at 9% in our white population. We know that when we talk about health insurance, 7% of our white population does not have health insurance at this time. We know in the African American population that is 30%, and in the Hispanic population that is 56%. We know that 8% of our whites are in poverty, but on the African American community, it is 28%, and it is 22% in our Hispanic community, and 23% in our American Indians. So we clearly see that the health disparities are there. We also talk about racism as a social system with multiple dimensions, a system of structuring opportunity and assigning value based on the social interpretation of how one looks. This unfairly disadvantaged specific individuals and communities, while unfairly giving advantages to other individuals and communities. We know that racism causes persistent racial discrimination, influencing many areas, such as housing, education, employment, and criminal justice. And emerging research now defines racism as a social determinant of health. Coronavirus has pointed out some of these gaps very, very clearly. Even so in a community where we are well aware of it and want to do the best we can do to actually diminish health disparities. We are not able to do it. We see our minority population disproportionately affected by coronavirus. Then just a few other things where the American Public Health Association has launched a huge campaign around racism, where the American Academy of Pediatrics has released a policy statement that clearly identifies racism as a core determinant of child health. We have done a lot of work in the health department, and Kari Kernan will talk about some of it, but I think today you are taking a bold step. And I would like to say that making statements and having phrases out there, that is not going to make change. Change needs action. And so with this resolution, we have 22 action steps in there that you as Board of Health, I would like you to become familiar with. I would like you to be supportive to the health department as we move forward with this. And I'm just going to mention a few of them. And you can bucket them potentially to internal actions that the health department needs to take. You can bucket them into what we need to do with our partners outside, and so on. So let me talk about some internal ones that we have to do together with you as Board of Health. And some of them are educational components, and I think every organization in this city is now trying to see what do we really need to know to understand before we can make change. So education, how this affects the population and the individuals. We need to make sure, and we have tried very hard to collect data for this community that identifies race and ethnicity. We need to implement more, however, routine health impact and racial equity assessments that really will tell the leader what our differences are and what the effects are of the policies that they implement. We need to be proactively identifying gaps in policies, and we need to identify clear goals and objectives, because honestly, if we don't do that, we don't see if we are making progress. And many times I share with you the data from the community needs assessment, and they show that we are making very little progress. And so I think with this proclamation today, we can start seeing some difference there. We also have, as one of the action items, that we would like to establish and support an Office of Health Equity and Racial Justice in the Health Department. Then we have some actions with partners in the community. We already are an agency that works very strongly with many of our community partners, but we need to do more. We need to really build alliances with those organizations that already are trying to address racism. We need to promote community engagement, and we have started to do that, but we need more of that. The community input is really going to be important. And we need to support efforts to strengthen social infrastructure to produce resilience in our community. And I have said that for probably 2-3 years. How can we build resilience in our community? We have to have some actions around promoting and advocating, and that's, I also think, where I need the Board of Health understanding for it. We need to advocate for relevant policies that address racism. We need to promote racial, equitable economic and workplace developmental practices. And we always need to support policies that prioritize the health of all people, especially people of color, by mitigating exposure to adverse childhood events. You've heard us talking about that. We have a report coming out pretty quickly. It's at the printer at this time. And we need to implement health in all policy, as we have shared with you too. Last but not least, we need to commit to assist in the review of all policies at the city and at the county level. Just assist individuals. Bring that equity lens to the table so that when those policies are up for review, we are focusing on that. As well as we need to review all our internal policy and practices, such as hiring, vendor selection, grant management, to determine if they can be improved to really bring that equity to the table. This will not be easy, and it will require all of us and the entire community to really work on this. But I saw a note 2 days ago, and I do think it is so emblematic to where we are today. It says, not everything that is faced can be changed, but nothing can be changed if it is not faced. And I think that's what we are doing today. We are facing this, and we are saying, all together, we want to move forward on this. So Kari Kernan, who is heading up and has done a lot of work on this resolution, and some of our staff, who have worked incredible behind the scenes on this. I want to thank all of them, but I would like Kari to share some comments with you. Kari.
Thank you, Dr. Poore. Good morning, Board. So a couple of things I'd like to add based on what Dr. Poore has shared is that this is not new work for the health department. This board established a health equity team actually about 11 years ago, back in 2008. And that internal health equity team has been very active. A lot of that work that they've done historically has really been around class, so the culturally, linguistically appropriate services assessments, looking at gaps, identifying how to fill those gaps, and really build up that capacity within the health department. Most recently, this board passed a health equity policy that was internal to the work that we're doing just this last January. Since then, we've been working on procedures, and part of those procedures that we have developed is an health equity review as we developed and looked at all of our policies over the last probably 18 months as we brought those forth to this board. So we have launched this equity review process and worked out some of the bugs, had a lot of internal discussions, and have really used that to not only educate ourselves, but really to build this kind of infrastructure within how we do business on a daily basis. We probably over the last 2 to 3 years have done some extensive training, and we have a lot more to do. So we've done everything from sending staff to racial equity training, implicit bias, cultural class standards training, and we have a lot more to do. So that's going to be part of what the work that Dr. Poore mentioned as far as internal. I think the one thing I do want to bring to your attention, and let me mention too that we have been strong partners with City Match, which is actually located here within Omaha, Nebraska, within the UNMC infrastructure. We most recently got approval from them and have been working with them on what's called a racial healing revival project. That is work that's really been specific within the North Omaha community. COVID put some of that work on the back burner, but it's really learning about the rich history within the North Omaha community, specifically the African Americans, learning from their personal stories so that we can better understand what these challenges have been, their challenges, and what that impact has been to their health and the health of our community, so that we can really think about what action steps and activities and policies we can put around that change as we learn more from this process. One of the whereases I want to bring to your attention is actually on the first page. It's on the 9th one. It's a new term actually that I learned as I was researching bringing this resolution forth. And we've gotten very comfortable and very knowledgeable around social determinants of health. So we talk a lot about where people live really impacts strongly their health and their health outcomes. So we talk a lot about housing and employment and education and poverty, and those have become really common everyday terms within the public health infrastructure. One of the newer terms is there's actually, and I think personally I really struggle with how racism connected, because I didn't see it as a standalone social determinant. So Dr. Kamara Jones, who's really well known within the public health field, has really come up with a new term called social determinants of equity. And racism is a social determinants of equity. And when we think about that, everything that we talk about within the social determinants of health, the underpinning of that is the challenges and the realities around racism. So until we really address the racism within our community, and Dr. Poore has mentioned the impact, we've struggled with the community health assessment data over the last many years, and why are we not getting better? Why is it just a little step forward and 2 steps back? It is my personal conviction that we have not really dealt with this at the deep-rooted level of racism, and so we've kind of blow this up at the top where we get grant funding and we get healthy neighborhood stores and we get physical activity and we build integrated care, but unless and until we really talk about what's deeply rooted within this community, we're going to continue to struggle to make impact on that data. So I think those are the highlights I wanted to bring forth. I think this is going to be hard work. It's not going to be anything that happens overnight. It took us 400 years to get here. It's going to take a lot. It's going to take community partners, not just the health department alone, but we want to be with our community members, helping them, walking this walk, and really being an advocate for them. And I think this goes to the second action step, is that we will do this in conjunction with community members. We want to hear their voice. We want to hear what concerns them. We want to hear what they think will make this better. Everything from institutional policies to the systems change that we need to think about. So I think this is going to be a heavy lift, but one that we are 100% committed to as a department with the support of this board. I think Dr. Poore and I'll answer any questions you might have.
I'm gonna come back to that. I'd like to put this together. Can we go to item 4, and then I'd like to ask for a motion to approve A, B, D, E, F, G, and H, and then we'll come back to discussion on that. So is there a motion from?
So moved.
There's a motion, there's a second. Okay, so with that, if anybody's here from the public that wants a discussion on any of those, but particularly item H, since it's in there now, I'd like to ask you to, this is your chance, if anybody wants to say anything. Okay, and then from that, if anybody from the board wants to say anything or ask any questions to Kari or have any comments of their own.
I have some comments, but you want to do that now? Or?
Yeah, I mean, if you want to have the questions to Kari, and then I'll give the board a chance to comment. So if there is any questions to Kari, there's not, then if anybody from the board has any comments, please go ahead.
Well, let me start here. I just, first of all, let me say to Dr. Poore and Kari Kernan, thank you all for the work that you have done to bring this to the board. And this is
Your mic on?
Okay, I'm sorry. Mic wasn't on. First of all, let me say thank you to Dr. Poore and Kari Kernan and all of the staff for addressing this issue and bringing it to the board. It is a bold step, as Dr. Poore has stated, for this board to move forward with this resolution. I want to caution, however, the work is just getting started. And unfortunately, I have been here before, and I've been here too many times before, where we continue to talk about this, and we pass resolutions, and we pass various items that we think we're going to eventually get at this persistent issue of racism. At some point, we're going to really get at it and really solve it. That is going to take, as was mentioned earlier, it is going to take a massive effort to turn this around. This has been 400 years in the making. And I'm going to turn part of this responsibility, or a good portion of this responsibility, back to elected officials, because elected officials have created policies throughout the years that have done nothing but damage people of color in this community. They did it with the Davis-Bacon Act. They've done it with several other pieces of legislation. They did it with 3 strikes and you're out. They did it with welfare reform that never worked. They did it by creating a Tea Party that said that they were not going to work with this black president on any single thing ever. It's the worst piece of racism I had ever seen, where you created a segment of a political party and said that no matter what this black elected president does, we are not going to negotiate with him on anything. That's unprecedented. It has never happened. And it only happened because a black president was elected to the United States. We have a series of issues that we have to deal with that are so deeply rooted that it is going to take us some time to work past this, and we cannot turn away from looking at elected officials who create policies, 3 strikes and you're out, crack cocaine laws, other things that put people in prison for years and in some cases decades. And they get out and they're broken people as a result of efforts by people who were elected to look out for the entire community. And they failed miserably, especially when it came to black and brown people. So for me, we've got to get back, and I don't have any questions, Dr. Poore, because I think you all have done excellent work and continue to do excellent work and have done so over the years and have demonstrated over and over again your commitment to addressing racial disparities and social determinants of health in a more meaningful way. But we have to recognize that elected officials, judges, and others have created and helped to maintain a system that is so virulent and so difficult for people to get through. We have to recognize that lending institutions and others have also been involved through various means, redlining, ignoring individuals and certain members of the community, people having to go outside of this community. I heard a story about Carmen Tapia, who runs North End Telemarketing, had to leave this state to get funding to have a successful program now that is hiring nearly 200 people. We need to be ashamed of ourselves, quite frankly. And so for me, I thank you all for doing this. It is a step in the right direction, but it is a very small step that needs to be built upon. And the action plans that you have created in this document have not been done prior. So there is actually an action plan as to what this Board of Health is going to do, and I appreciate that more than you all will ever know. But for those who have been in the streets, and for those who have cried about this in the last couple of weeks, the real work starts now. The real work starts now. Thank you all. Thank you, Mr. Chair.
Thank you. Anyone else? Mark.
Kari and Dr. Poore, first of all, I'd like to thank the Health Department and everybody involved in this particular resolution. By calling it a crisis as opposed to an epidemic, will our measurements of our success or our amount of change be measurable?
You know, I think yes to answer that, because Dr. Poore has shared a lot of data with you this morning, and actually the data table that we kind of connected to one of the whereases is just a small snapshot of all of the data that we really have to tell a more significant and impactful story. I do think, and I'm going to just share some of the processes that I've been kind of going through over the last 2 weeks. When this board declared an epidemic back in 2004, you know, I'm a registered nurse, so that made perfect sense to me. You come in with a symptom, there's a diagnosis, a treatment, education, and it's very black and white. This to me is much more, it's hard to kind of grasp onto. So I think as we look at these action steps, the one thing we can fall back as a public health entity is the data. And that's really how we're going to tell our story. And we're going to make sure that we tell the story so that it's impactful, it resonates, and it's true to the members that we're trying to communicate with and for. So I think that will be one of our challenges moving forward.
Okay. Anyone else? Okay, then I want to say a few words here. Let me follow with you know, thanking the staff, and to the people watching. I want to walk this back a little bit, because as we were talking about this for the last week with Kari, and then I think a call I had Monday night with Dr. Poore, I can't help but think of now of I think probably only Marty had the chance to serve, and myself to serve with Frank Peake. And when this was stated that it was not new work for the Board of Health, if any of you have served with him, the political will wasn't quite there, but this is the spirit of Frank Peake all over. And if he was here today, he would be more than pleased from there. I mean, if there were few people that I knew of here that were godfathers in public health and where it stood in regards to racial inequities, it was him. And since Frank Peake, that's been a constant on the agenda here, and even to the point where, you know, the staff wholeheartedly embraced this over the last couple of years to really dig into it. So, you know, for the last 4 months or so, you've seen the infectious disease face of public health. And this is bold, of course, in what it does with racism, but also, you know, it adds as another coming out party in respects to this for public health and the other things that hopefully you will see what it does in your life. My goal to put this on Zoom today was, I don't know if it's working exactly, but if any staff are there on 42nd Street, you know, I wanted to thank you all for this and know that, you know, I've heard your antsiness in what to do, and my hope is this step today is the first step for the staff and not only the public to full-throatedly grab hold of addressing this issue and going ahead to address it. As Councilman Gray said, this is built over 400 years and it's not going to start overnight. But also to Marty Wilkins' question of a crisis versus epidemic. You know, I was asked this question one time about the protests versus the virus, and you know, there's a lot of people that feel it's like we had a 400-year virus. And so when you say a crisis versus epidemic, the pandemic was a crisis that warranted a certain amount of response. That response triggered monetary resources, policy change, behavior change. And I think there's significance when you call this a crisis because of the behavior and other changes that need to come with it. Over the build-up, over the last 3 weeks since the George Floyd murder, I've seen, and they've slowed down this week after, but some in pace of 3 to 5 statements a day from people. And in regards to, you know, direction and conversations that I know I've had and a few other people have had about what to do, I think now the passing of this resolution today puts this issue in a public policy arena to put it on the agenda for people to address. So there's been, you know, at least my time in life, you thought there were pivot points, and at least now I hear people where I think the political will is there. And that is key more than anything. So my hope is today, you know, by passing this, it continues to elevate the seriousness of it, but also now that the time is now, it puts this on paper in a way, in an agenda way, that my hope is that industries from business to education to housing will seriously take a look at all of this and peel this back. Because I found myself over the weeks, the experience that I've had with this personally, but also trying to listen to that younger generation and still listening. But one thing that I've heard, and that it is that's there, is that this is a policy issue. This is a structural issue. And as was talked out now, the protests in the street have to shift to that, and I hope that they take that momentum and push it into the policy realms. So, you know, my thought today is this is the beginning of a first step, and I want the public to know that personally, and I think from the Board of Health's perspective and the staff, that we will not shrink from this moment, and today is the first step in trying to make sure that we move this dime and get progress on this. So with that, that's all I have to say, unless somebody else has something to say. Okay, so
Sorry, Mr. Rogers. I just have a quick comment. I also want to thank the board for putting this on our agenda. I agree that it's alive and it's happening, but I also I want to put this on the public side and make sure that we all understand that as much as we want policies changing, we also have to take personal responsibility of our own actions, starting at home, and also educating ourselves on officials that are running for these public offices, making sure that we raise our voice when the time comes for voting these officials into office, making sure that we're following our roots and our beliefs, and that we vote for people that have the same beliefs and respect for everyone's life, for everybody. Again, I feel like my community needs to stand up for all Blacks Lives Matter and all whites and Hispanics. But again, please make this an action at home and educate your children. It really starts at home. And from there, educate yourselves on your voting rights and your candidates that you're voting into office to make policy changes. Thank you.
Thank you. Okay, not seeing anything else. There's a motion to approve those items. Roll call.
Gray,
Yes.
Rogers,
Yes.
Wilkins,
Yes.
Espinoza. Yes. Weiss.
Yes.
Wade.
Okay, we'll go back now down to item 5B, Dr. Poore, and the coronavirus update.
Thank you, Board. I just want to give you an update of where we are with coronavirus at this time. Potentially last week we had 650 cases in Douglas County and a positivity rate of 10.6%. That has been the lowest positivity rate since the last week of April. So we have actually seen our positivity rate decreasing, very slight, but consistently, so to say. I looked this morning, we have a total number of tests, about 45,662 that have been done. That's 8% of the citizens of Douglas County. Our case count yesterday, the last time, was 5,943 cases. When you look at those cases, those close to 6,000, 80% of them are in our working category. They are people 20 years to 65 years of age. We have 10% of our cases that are in our young population, less than 19 years of age, and we have 10% above 65 years of age. So I think that is important to just keep in mind. And if we look at those 80% in our working community, 30% are actually 20 to 34 years old. So usually that actually, in my mind, it is potentially a good sign because those individuals are healthy and the health outcomes are less severe than if we would see it in our more vulnerable population. When we look at race and ethnicity, as I shared with the board last month, 77% of our cases are in our minorities and 19% in our whites, and there are some unknowns in there. When we recover cases, about a third of them are recovered up to now. So we have called people back, asked them how their symptoms are, and they have said they actually have no symptoms anymore, and that's about 33% since we started this, and that was the first week in March, of course. One of the measures that now, even on the national basis, is probably one of the better measures of the severeness of the pandemic is hospitalization. So we are starting to look at that data very, very closely, and we have since the beginning, but even over the last few weeks. And I just want to give you some comparison. And I looked at the week that ended 2 weeks ago and compare it to this week. So 2 weeks ago, on 5/31, we had 161 patients in our hospitals. As of the 13th, we have 119. So from 161, we have come to 119. And then from those, how many of them are on a ventilator? Because that is very significant to know, especially because of the seriousness of the outcome. On the 31st, we had 49 of those on COVID patients on ventilators, and on the 13th, we have 19. Let me say this correctly. We have 49 on the 31st, and we had 31 on the 13th. So from 49, we have come down to 31. So we see from those symptoms, from those data points, that actually our hospitalization rates have come down in the last 2 weeks. Now, we have had an uptick of deaths that have been reported to us, and we now are at 66 deaths. As of yesterday, we were at 65. We are reporting one new one today. So 66 deaths. What is important there, too, I think, is 70% of those are in ages 65 years and above. 70% are in the older population. That's what you would expect. 60% are in whites, and 20% in Asians, 15% in African American, and 5% in Hispanic. That's for the death. And only 10% of those who are dying do not have any underlying illnesses, no comorbidities. So to a certain degree, we always said the vulnerable population are those with comorbidities, and that's what our data shows at this time. We also are reporting the second child with this multiple inflammatory syndrome, and both of those children, we had 2 so far, have been hospitalized at Children's Hospital, but both of them are released and are back home yet. So that's good news. But it also should increase, again, the awareness. How can we prevent that syndrome from happening? Only if we do not have anyone in our household who is COVID positive, or if they are positive, they are really taking isolation seriously. In both of these cases, there were positive cases in their households, and that's how the children got infected. And then we have this lag time, potentially 2 weeks or so on, until children are symptomatic with these symptoms. And these children are very severely ill, so it isn't a child running around. It's a parent who notices that this child needs to have hospital care. Also, when we look at our doubling time is the highest it has ever been. It's 37 days, meaning it takes 37 days for our case count to double. We also are looking at clusters. We have 147 clusters in our community. 2 of the largest clusters are meatpacking or food processing industry. We have 23 of them in that cluster. We have 18 long-term care facilities that are in the second cluster. So we have 2 large clusters, food processing, long-term care. When we look at the cases, the largest number of cases are in our food packaging, food processing industry. Mainly 1,194 cases are in that industry. So that's 50% of our total clusters. All the other clusters are very small. There are 2 people, 3 people, 4 people. So that's important to know, because we want to know what is the percentage in cluster compared to community acquired. Community acquired means when we do case investigations, nobody knows how these individuals have been exposed. They have no connection. And so community acquired used to be around 29%. 29% of our total cases, the individuals could not figure out where they have potentially been exposed to. It is now up to 36%. So we are increasing a little bit. That could have something to do with releasing some of the restrictions, and therefore just people walking around. And let me just use one moment here to say what really would be helpful, and that is wearing masks. We are now relieving some of the restrictions, and for us to move forward is really making sure that we know how important it is to wear masks. There are studies over and over that are telling us now about the effectiveness. I read a few of them this morning, actually, before I came. There are countries like Austria, like Czechoslovakia, who have made masks mandatory, and they saw the case count drastically decrease, even though they opened up the economy. And that's what we are dealing with. We want to open the economy. We want to have a normal life again, as you can call it normal. But we need to do the prevention, which is wearing masks. Why does it work? Because some people may say, well, I'm not sick, I'm not wearing a mask. You don't know if you are sick. There are 20% of the individuals who are asymptomatic and therefore able to spread the virus. We know the virus is spread by particulates. We know the virus is spread when you talk, when you sing, when you shout. But if you do not know that you are asymptomatically positive, you may do those things, and you are exposing the person next to you who is not wearing a mask. So I really want to say the evidence is clear that masks work. We saw the article from the infection control experts at UNMC who put it in the Omaha World Herald and said, it does work. So let's do, it's uncomfortable, I understand it completely, but it does work. And we want to go back to a normal economy where restaurants can be open up. And I'm looking at John Wade, where people can go around and start to go shopping again. And we can do it, but we need to take proper precautions. So that's just my spiel this morning. I think I want to share with the board, because I don't have opportunities often to share with the board what other work that's going on in coronavirus. You are, I'm sure, very well aware of epidemiology, what they do, and they do a fantastic job. However, you know, they have been tasked to do contact tracing to so many individuals. They have now reached out, we have now reached out, and through the state of Nebraska, there is a contract with PRC. You all know PRC because that's a consultant who does our community needs assessment. They are now also training close to 200 people on contact tracing. And the DHHS has contracted with them. So we are working with PRC to actually increase our capacity to do contact tracing. Contact tracing is important. It needs to happen quickly when we have positive results, because we need to share with them, you have positive, you need to isolate yourself. We cannot let 2-3 days pass, because otherwise you may not know your results and go around the community and actually spread the disease. So I'm very happy. Our staff is training the PRC team. They were doing training yesterday again to really make them more aware. They know the community as we do know our community. They want to be part of our team. Then I want to talk to you about our information line. And our information line had a big celebration last week, actually, because we had the 10,000 caller on the information line since it started. And I have to give shout outs to that group. That group has just been phenomenal. And I look at them, if I sit back and every night I get a short report, a short summary what the calls were all about. And I kind of categorized them into 3 phases. Phase 1 was, you know, it was mainly about information. What is COVID? What do I need to do? What are the symptoms? How does it look like? So really kind of this hotline questionnaire. So it was really important that we had good data, good information, consistent information, because we have some callers who we call multiple frequent flyers. They call often, and they want to make sure that we give the same answers. So that is something that we had to learn through this too. So that was phase 1, kind of that general information. Phase 2 was when we started to have the direct health measures. People were in an uproar. At first it was hair salons. different business types who were really wanting to know, how can you do that? How can you shut us down? And so on. It was very uncomfortable for staff. A lot of people really, really frustrated because we closed down this community then. So that was probably phase 2. Phase 3 was when these DHMs came into in effect and we lifted certain restrictions. Well, what does this mean to us? How can we do this? So it was really having staff know exactly how do we interpret all the different regulation in the DHM. And then a new thing started where people were calling and saying, you know, I need to have a letter to go back to work. You need to share with me that I have been tested, or I can get out of quarantine, or I need to be isolated. So then there was a lot of this one-to-one people calling about test result, and I call that phase 3. I think what is interesting over the last month or so, about a third of our calls are in Spanish. So we really needed to bring interpreters into that line. The highest case count were 280 calls a day. And sometimes these calls can take a half hour. They usually are not just a simple answer. They take a lot of time. There are some really issues that we had to work through. We worked through pretty quickly and saw that we couldn't have all these individuals in one room. We needed to order cell phones. We needed to have people work from home so that we could distance ourselves. In the health department, we saw that our phone system wasn't really made up to do all this. So we had to work with .com and did do it quickly. I also want to give a shout out that a lot of people do not know that has to do with Ppe Distribution. All the PPE is ordered by the state of Nebraska because that's how better prices can be get. And then the health department or the organizations put in orders for PPE. And at this time, remember, it's still on a priority basis if you actually are treating patients or are being around COVID positive. That's the priority. But then all that PPE comes into Douglas County in our warehouse. And up to now, we have given out more than 1.5 million pieces of PPE to more than 500 organizations into this community. So we have become a distribution center. That's not usually what public health does, but really we needed to ramp up on that. We have the community health workers or the ambassadors. I've talked to you about that before. They have now served more than 200 families or households, meaning following up with these families, trying to see what they need, make arrangements so food can be delivered to their home directly so they can isolate at home. We have seen food insecurity is probably the number one issue that these households face. Number 2 issue is rent assistance. Then they have issues with electrical bill and so on. So that group is really working tremendously well in our community to address what some of our minority communities specifically are seeing. Communication. We had to switch very quickly because we saw not everybody is going to understand English, and that's why we have the interpreter here today. We also are realizing that not everybody can read. So we are starting to do a lot more YouTubes in Burmese and some of those languages to really make those people understand what we are talking about. I want to talk just quickly about testing. We have 2 new efforts that are going on, well, especially one I want to share with you, and that is in South Omaha on 50th and G. We have now, through a collaboration with One World, Douglas County Health Department, and Nebraska Medicine, we are having a drive-through site at 50th and G that is open for the next potentially 6 or 7 weeks, every day for 4 hours. It should be an easy drive-through. We have 300 tests there every day, and once they are used, the site will close and will open up again the next day. We also here in North Omaha, we have NOAA that is trying to do a drive-through site at the church close to them. Again, an opportunity for North Omaha citizens. And we know that both of the FQHC, One World and Charles True, they have a good number of tests available, and they were telling us yesterday that they are not using all the tests. So individuals who need to get tested or want to get tested should really use those locations. And then we have Test Nebraska still going on and will be going on for probably a month at a time. They are now at the CHI Center downtown, but those locations potentially are going to change, so we are going to move around in this community. We need to find somebody who's really going to do that testing, because the National Guards are going to be pulled back. The other few things that we need to do now that we had never had to do is businesses that are trying to open up and that are in an area, in a venue that has more than a capacity of 1,000 people. They need to present a plan to the health department, a reopening plan. So we have a reopening application on our website now that those businesses need to fill out to really tell us, how are you going to do social distancing? How are you going to do check for temperature or symptoms? How are you going to do safety with your staff? What are you going to do in regards to all these different things? And so that has been started about 2 weeks ago now. It's going to change again now with the new DHM getting in effect this Monday. So these plans need to be reviewed. Reviewed plan from the zoo and big chunk, stock, farmers markets, and so on. So that's a new endeavor, and we have a whole team working on that. We now have a whole team working on school reopening, because schools are now coming to public health and saying, what do we need to do to be able to open safely? And if we have a case, how would this look like? So our Epi team and our medical consultants are now working with schools to really try to work through that. Long-term care facilities, they are going through a movement now too, where they want to reopen, very rightfully so, because many of these family members have not seen individuals in the nursing home for quite some time, and there is potential mental stress on these individuals. But to do actually some reopening or some visitors being able to go to those sites, they need to do some baseline testing, and that's starting right now. And then, as I shared with you, we are going to have DHMs for phase 3 opening up Monday. Again, that's going to lose some of the restriction, especially in the restaurants and bars. There is going to be kind of an open, it's not by capacity anymore, but social distancing and guidelines that the Nebraska Restaurant Association put together are still really in effect, and are probably really, really important if we as a community want to be successful in moving forward. So let me thank you and share this. I cannot tell you how proud I am of our health department. They have stepped up whenever there has been a need. They have stepped and said, let's see how we can do it. Let's see how we can put these systems in place to really make this work for our community. So my thanks to them, my thanks to the board who helped us get through this. We are not through it yet. It will go on. We potentially may have a second wave, and Kari will share with you a little bit now what we are already planning for in the future. So do you have any questions? Yes.
You got a question? Go ahead. Yeah. Great.
So a couple of the questions, Dr. Poore, that I have mostly revolve around the testing. So am I right to think that testing availability now has gotten much, much better as far as being able to get tests out to more than obviously just the high-risk individuals?
So testing has really opened up. Test Nebraska has now opened it up. You remember they were, you had to be 60 years old, or you had to have an underlying illness, or healthcare worker, or emergency responder. They have now opened it up to 15 to 35 years old too, and they want to do that in most of the counties besides Douglas, they've actually opened it to the entire population. That has worked very well for those people who are able to do the assessment online and have an email address, because they then get the results back very quickly. That it's a very slick process if it works. However, what we are finding out that not everyone has an email address. Not everyone really feels that the questions that are being asked are not a little bit intrusive. So yes, testing has increased widely, so to say, through Test Nebraska. Yeah.
Okay, and then, so you mentioned the drive-through testing down on 50th and G each day. Is that, are people being referred to there by healthcare providers, or is that truly, hey, you know, I just want to go get tested and I just show up to get a test?
Yeah, it's probably, I want to be cautious that we are not just opening up for the community. It really has put in place because South Omaha, especially One World, has said, we cannot take care of everyone. We can take care of our patients, but not of household members. So really it is an opportunity for South Omaha because we also have food processing plants and we still have outbreaks in some of those plants, or at least additional cases, not so much outbreaks, but additional cases. So that's really the priority, I would say. It's for South Omaha. But I think nobody will be turned away.
Okay. And then I think my last question, I've known a couple individuals that have gone to be tested. I think it started because they had some symptoms and they got referred to it. And I guess this question is just for my own clarification. So they took what I guess was referred to as a pre-test, where they, is that, I don't know.
No, the pre-test may just be asking them questions about, have you symptoms, how old are you, what is your profession? I have taken the test myself, and
But that was a questionnaire.
that's a questionnaire.
They took some type of test where they actually came out as a false positive, and then they had to go in and get tested from someplace else. Does that even sound?
It doesn't sound right, but
Okay.
there could be, you know.
Maybe some misinformation there.
Yeah, maybe, but it may also be there could have been antibody testing, because now we are seeing some physicians are going there. It could be testing that they did in the clinic, and sometimes that testing is not as accurate either. So if they have a nasopharyngeal swab, that's really what is kind of the gold standard at this time.
Okay, so and then there are other tests that don't use the swab. Is that?
Yes, there
okay.
are. There
Okay,
are.
that probably
Yep.
is what it was. Okay, thanks.
Dr. Poore. Let me leak into, I guess I just got a curious question. Let me leak into the reports a little bit. So Sharon Wade's gonna come on. She's gonna be the contact for all the school districts, right? I'm assuming.
Sharon Wade is an OPS public
Retired.
health
Okay,
nurse.
she's gonna be the contact for all the school districts.
Well, and she will be working with the team, yes, with
Okay.
the epidemiology team on how to prepare schools, yes.
So I guess we basically, I'm assuming from August on, gonna be walking hand in hand with them for the whole year, I'm assuming.
You know, it is, potentially it is, because as I say, there is no question, school is going to start and you're going to have cases, and so this may definitely go into fall. I think till we are really kind of familiar with what needs to happen, yes. So I would foresee Sharon to stay around.
Yeah, because I'm assuming it's been when outbreaks or something happen, then we get real close with them. But I'm just reading through this and my own questions. I'm assuming it's going to change a little bit because we're almost like an advisor to them, almost a hands-on advisor to them. I'm assuming because they technically fit over this 1,000-person thing, so they're not exactly checking with us. But the scenario I keep playing through my head is, who is it? Us that's making this checklist? So, for instance, they getting, my understanding is they're getting 3 washable masks a day to the students, and I've been thinking through all this ripple effect. So, you were saying you're not so much concerned about the kids passing in the hallways is when they sit. So kid has it. Then you got this potential tracing thing through the whole school. Then you got the potential tracing thing through all the families in the school. And then you got the potential tracing of the job that one of those family members may go to. I don't want to paint the scenario, but it almost is like, it's not totally died down yet. A lot of people aren't adhering to the mask thing. I'm just wondering how much we thought through this, or is that just too much doomsday to be talking about?
No, I wouldn't say it's doomsday. First of all, I can tell you we are joined at the hip with the superintendents. I mean, I'm on a call with them every Thursday morning at 7 o'clock. So they really want to see what the advice is from public health. And they are also telling me, some of the educational things that are not going to work. And they are very honest about some of those things. So I think it is not doomsday what you are describing. I think we have some of these instances. If you think about whooping cough, we have them every year where, there is a child infected with whooping cough, then we isolate, we identify who has been sitting around that child in the classroom. We give information back to parents. So it's just more scenarios, because now potentially also, like you are saying, it could be what does it mean if a household member is positive? What does it mean for that child? Should that child then stay at home? And those are all the things that we are working. What type of PPE should school nurses wear if a child gets sick at school? And so those are all the scenarios. Those are the big discussions that are occurring. And I'm learning a lot, that schools are very independent. So the Commissioner of Education, they make guidelines. They are pretty broad guidelines on the 35,000-foot level, but then it is up to the schools. And I'm already hearing that one district says, this isn't going to work for us, because the children that we see and the family they come from, we can't do that. So there is going to be variability from school to school, and I see that very distinctively talking to the superintendents. There's going to be variability from an urban county versus a rural county where there are no cases over the last month or so. So I think we just need to be prepared. I also see, and I have been the recipient of many emails. I've seen parents who really play a very important role and want to have a say in how these things are going forward. There's a lot of things about children wearing masks and why not, and so on. And I think every superintendent in this community gets bombarded by some of those emails. So there are some very difficult issues that I think we need to work through. We have time now in July potentially to do that. Most of the schools, what you have heard about middle of August, that's potentially when they feel, but there are preparations that need to occur now. They need to order PPE, they need to put policy, they need to put SOPs in place and so on. They need to do training. They need to do training to their staff too. So
yeah, and I guess it'll evolve every month, but my main piece is, so we got CARES money that helps with the tracing and paying for that up to December 30th. But my thought is, with the vaccine being out there, depending on when it comes, I guess I'm trying to think through budget stuff, because you're almost going to have to keep people on. The benefit we had in March is that they won't spring break. Now you're going to have all of them together and say you got funding to December 30th. Say they come back after winter break, something pops off, then you have to kick into that mode all of a sudden, and it's going to spread like a monster then. So I'm just trying to walk this through to think how to prep numbers wise. To keep staffed up.
I see what you are meaning, but I really hope we can use the time to put systems in place. you know. So we are hiring a lot of part-timers right now to help us, like Sharon, to help us out in this time, because to put these protocols in place, that takes time, that needs to be negotiation and so on. So I hope a lot of that work can be done. My hope is too that depending on vaccine, when a vaccine is going to become available, there may be additional funding, or we can carry the CARES fund for a longer period of time. I'm not sure about that. That's the least of my worries at this time. The worries is to get things in place so that schools can safely open.
Well, and I'm just trying to lay the groundwork right now, because I'm thinking you put on all these people to ramp this up, and you can't just let it drop. So you may not have the same number of people, but it's going to be more than what it's last time to maintain this, because I think the mindset now is it could come at any moment. So I guess I'm just saying that for the public and the board's view to look through that. There's going to be some people that are here that may be here for the long term. We got to find some way to budget that. So
I'll come back to the board.
yeah, I'm just trying to prime the pump for it, because it's a new world now. Anybody else? Okay. Dr. Poore, you good? We'll go then to presentations in the mass vaccination planning. Kari.
So that was a great tee-up for me to talk a little bit about mass vaccinations. I know Dr. Poore mentioned last month that we've started planning, and I had several staff say, why are we thinking about this already? And I said, because this is going to be huge. If all of you were here around 2009 when H1N1 hit, I think this is going to be larger than that, and that's just my guess. So we do have a team that we pulled together that we've started to think about mass vaccinations, and we learned a lot for those of us that worked through H1N1. One of the things that we've identified, because this is so new and unique, and the virus will still be out there, we have to think about how we're protecting staff and responders as we're actually registering and having people come through. So if you remember, we did a lot of H1N1 in schools because they had long hallways and places to park. We had people get out of their cars and come in. We don't want that to happen this time, just because we don't want that. We can't even imagine how to manage social distancing and all those kinds of things. So we're making a number of assumptions as we think about mass vaccination. So there's been a lot of talk at the national level about the timing of this. I was just on a webinar last week. This will not happen this year. More than likely, we'll see a vaccine come out probably the first quarter sometime in 2021. So planning-wise, we want to make sure we have our plans in place by no later than the end of the year. Phase 3 trials are now in process, and according to the national experts, those will be complete by July. And we'll start to see some continuation of that before we get FDA approval that the vaccine is safe and effective and is ready for administration. We have no idea if there's going to be a booster. We have no idea the volume that's going to come into the state of Nebraska. We did get confirmation yesterday that as the vaccine more than likely comes through the CDC, it will come directly to what we know as VFC providers, so Vaccine for Children. So many of those are healthcare providers. We are a vaccine provider, FQ8Cs are a provider, and more than likely they'll expand that out to health systems. So we have to think about how it's actually going to be distributed within the community. We are responsible for ensuring that the vaccine is available to anyone who wants one. They're doing some polling out at the national level that only about 50% of the folks are saying they're going to get it. So it's not a mandatory vaccine. It's really you come if you want it, and we'll make sure that it's available. So we're making a lot of assumptions as we kind of move forward with our planning efforts. So given the challenge that we're not going to have people get out of their cars and come into school buildings or into faith-based organizations or big building entities, we're actually doing an approach where it's kind of a two-prong approach. We're going to actually have drive-through clinics, much like we're doing Test Nebraska now, in very large parking lots, and we're working with our law enforcement officer partners to figure out where are those best locations. We're planning that we're going to operate 3 simultaneously, so someplace out west, someplace north, and someplace south, so that people don't have to figure out how to get from a long distance to another distance, especially if they don't have the resources. Through these drive-throughs, they'll come up and register if they haven't already pre-registered, so we'll make sure that there's assistance to do that. We'll have express lanes if I'm just the only driver in my car. We'll have lanes where there's 2 to 4 people and have actually vaccinators on each side of the car. And then we'll have probably 3 lanes if you've got 4 or more. So if you're bringing vans in and you're bringing family members and that type of a thing. We're really trying to do everything we can to lessen the amount of volume that's coming through the drive-through. So while those 3 drive-throughs are functioning simultaneously, we are also going to be working with and identifying folks that can't come to the drive-through for any number of reasons. I don't have transportation, I don't understand the directions, I have cultural considerations, language considerations, I'm homebound, I'm physically or mentally disabled. So while the drive-throughs are happening, we're also going to be bringing in what I call mobile neighborhood vans. So we've had conversations already with the VNA and other partners to say, just tell me, sign me up, I'm ready to help. So I think that's part of the staffing challenge. And so as we get these vans, we're actually identifying geographically through GIS mapping where we will put these vans and for how long. So we're in the process of doing that. But for example, we've already had conversations with the Omaha Refugee Task Force, and they have given us probably 18 different locations that if we parked a van on this corner or in this parking lot, within a 1-mile radius, we could really hit that refugee immigrant population easily so that they don't have to worry about what are they telling me to do and where to go and how to register. We're going to do that across probably the north or the east and south boundaries east of 72nd to start. Not to say that we couldn't expand past that, but we want to get a sense of what that's going to look like geography-wise and then what those resources are going to take. I think part of the challenge too will be meeting the need of everybody who wants it right away. So these drive-through clinics are not going to be a one and done. We will have that until every need has been met, and the neighborhood mobile vans will be out there, and maybe we'll go to the same location 2 or 3 times. Hours of operation is to be determined, again, based on what we're trying to do. So we could operate the drive-through clinics for maybe 8 to 10 hours and then come back the next day, and the next day I have to make sure that I'm really taking care of my staff, that they don't get burnt out. And part of the challenge will be finding enough healthcare providers that actually are able to administer vaccine under their scope of practice. So that'll be part of the challenge. I think another effort that we're doing is that we do have a number of community partners that are actually going to function as a closed pod. So when we talk about a closed pod, it was back in the day, also during H1N1, that if I can get the vaccine to you and you actually have people that can administer you, so you have healthcare professionals that under their license, they can administer the vaccine, and you can maintain cold chain storage. So that's going to be a piece that we have to commit to CDC, that as we get the vaccine and take it out into the community, we can ensure the safety of that vaccine through cold chain storage, because if it gets above or below a temperature, then we have to call CDC and they may say that's not usable. But so we really have to make sure that we maintain that, so it's maintain the efficacy of the vaccine as we go about distributing that. So for example, again, with conversations with VNA, they say if you can get us the vaccine, we'll vaccinate our staff, the family members of our staff, the clients that we're serving, and the family members we're serving. Other partners that we're working with that are doing that is OPD, Mutual of Omaha, and we've gotten a list from our the well-being partners to see who else we can call that may have that capacity. And so that relieves a lot of the stress and pressure of those folks coming through drive-thrus and have to worry about getting to the neighborhood mobile vans. One of our team members is actually having a conversation with about 15 faith-based organizations. They're very interested in this closed pod. I think some of them has parish nurses. So this is really kind of a threefold approach as to how we're going to get the vaccines out to those that really want them. I think, I mentioned a lot of the groups that we've talked about for consideration. We're going to be working specifically with our homeless population, partners to the Omaha Housing Authority, especially within the towers, the senior population, long-term care facilities. Health systems currently have a plan internally, so they'll either get the vaccine from us or it will be a direct shipment from the state. And the management of the vaccine is actually going to be happening on the Health and Human Services side through their Vaccine for Children program, and we work with them every day because we provide immunizations within our clinics. So I think that'll be a fairly easy relationship, and the communication systems are really there. We are exploring partnerships with pharmacies, dental offices, as well as I mentioned faith-based organizations, because many of them can administer vaccines and know about kind of that medical oversight of that. So I think there's a lot of potential there. I mentioned a lot of the concerns with staffing. We're also going to be working with our academic partners to bring in students from the schools of nursing, schools of pharmacy, the medical schools, because those folks can vaccinate if they have oversight from their instructors. So I think that'll be a great resource that we can tap into. And then obviously our internal staff are going to be paramount, and then it'll be all staff on board as we are working towards this. I think one of the other things that we have brought forth is we actually have a communication team that's working just on vaccinations. So the anti-vaxxers are out there. They're having conversations and they're sending messages out about concerns of not just COVID vaccines specifically, but vaccines in general. So Phil Rooney through our communications team is already developing just general information about vaccines, just why they're there, the impact that they do for the health of the community, the safety of vaccines, efficacy, so that when COVID does come, we don't have kind of a more of an uphill battle to really communicate the support that this vaccine is going to provide. I did request some data, so I think we've all read in the news that they're questioning what are regular vaccines, so our vaccines from infants from 6 weeks up to 5, and then our adolescent vaccines all the way to those that we get when we're a little bit older. Because I want to see if that's true for Douglas County. So I've asked for some data from the state to see what is really happening with our immunizations, because many of these kids have not gone to the doctor as we put stay-at-home orders in place, or the recommendation to do that. So I think that's going to help with some of our communication and our messaging. And I think it's been extremely beneficial in the work that we're doing just around COVID in general, that we have made new partners, especially around communication, that has really helped us reach our minority populations, our vulnerable populations, and those that really do not speak English as a first language. And so that has been really helpful, and we're going to continue those partnerships. Probably the last piece that I think is going to be one of the other big barriers is this whole registration piece, and we're running into these challenges with Test Nebraska just on, I don't have access to internet, I don't have an app that gives me a QR code, I don't have an email address. So one of the things that we're trying to work out is that as data is entered, more than likely it will go into the Nebraska immunization system. That's where all our vaccine data currently goes now through the VFC program. So we're really trying to figure out, is there something we can do within the REDCap system? I'm working with Dr. O'Keefe on that, as well as the GIS staff, to see if there's a way that we can somehow mirror what Test Nebraska is doing with their system, but make it much more user-friendly. And we'll have a plan that if that works for some of the population, what's the other opportunity for folks to easily register that don't have those access to those resources. So we're probably I told Dr. Poore, we're probably at the 30,000 foot level, just coming up with all these ideas and making sure that we have equal access and everybody can get the vaccine that wants it easily without barriers. And so now we'll start to dig a little bit deeper into the weeds as we bring these plans forward with a lot more detail and partners. Any questions I can answer?
So Kari, I'm just curious, I've never asked, does COVID change anything about how we're going to give regular flu shots this year?
No.
Okay.
Yeah, and we will strongly recommend influenza vaccine for everybody, because I think that will be the challenges. Some of the signs and symptoms from influenza are similar to COVID, and so we really want to make sure that the community is protected on the flu side until the COVID vaccine becomes available.
Okay. No questions.
Okay, thanks.
Thank you. Alrighty. Any board members got any questions for the reports to any other staff? Alrighty, no need for executive session. With that, is there a motion to adjourn? The motion is second.
Second.
Roll call.
And Wade,
Yes.
Ray,
Yeah.
Rogers,
Yes.
Espinoza. Yes. Wilkin.
Yes.
Okay, thank you all. See you next month. Appreciate it. Yes. At the beginning. Yeah. No.